Hi, thank you for joining me today. My name is Priti Lakhani. I am an board member of the Alumni Association at the Harvard Chan School of Public Health. And I'm excited to have Paula Rashan here with us today. Paula is a geriatrician. She is a health services researcher, a professor, and the founding director of the Women's Age Lab in Canada. And if that wasn't enough, she's also a proud alumni of Harvard. So we're very lucky to have her here today, and she's going to talk a little bit about promoting the health and well-being of older women. Paula?
Thank you so much for the introduction. You know, Harvard certainly played such an important role in my career, and it continues to do so. So my interest in aging goes back to my grandparents. My grandfather lived to almost 103, which I know is kind of hard to believe. And my grandmother lived until her 90s. And I remember being at his birthday, and here's a picture of me with him at his 102nd birthday, and really thinking that, you know, not all older people live such long and active lives. Now, my research interest in older women really started at Harvard. And it started when I took a meta-analysis course with one of the leaders in the field, Dr. Thomas Chalmers. And as part of that course, I have this sort of recollection of being given these boxes of clinical trials of drug therapies for the treatment of arthritis. And basically the task that we had at that time was to go through all of these trials, to review them and to synthesize the information. And I remember, you know, in reading through what must have been like hundreds of trials, I started noticing that they really didn't provide very much information about older people or women. But at the same time, you know, I was a geriatrician, and I knew that arthritis is a condition that increases with age. It's more common in women. And so to me, there was clearly some sort of a mismatch going on here between who was being studied in these clinical trials and who actually was using these drugs in clinical practice. And I think it's fair to say that this inequity has really been the focus of much of my research. And here I am, a picture presenting the results of this research study that I did with my colleagues at Harvard. It was really my first, I would say, published study, and one that I presented as a poster at a national meeting with my infant son. So I think it's fair to say that Harvard provided me really with the research training, the mentorship, and really the opportunities to collaborate that have continued to this day. So the research that I did that showed really the lack of information about older adults and women in clinical trials is probably reflected in the policy environment. You know, it wasn't until the 90s, which was around the time that I was at the School of Public Health, that women were required to be included in research studies. And it really wasn't until, you know, somewhere around, 2019 that older adults were required to be included in clinical trials. And this, in part, I think explains why there's really relatively little information about older women in drug trials I was evaluating, and maybe why, you know, the currently available drug treatments, even today, that are being used by older women are not always suitable for them. The research that I've done over the years designed to optimize, drug therapies for older women really did start with that first project and has continued to evolve over time. So along with a colleague from Harvard, we wrote about the prescribing cascade framework in the 1990s. Now, a prescribing cascade occurs when a drug therapy is prescribed, a side effect develops that's misinterpreted as a new medical condition, and then another drug is prescribed to treat that side effect. This prescribing cascade framework has now been written about by researchers from at least 16 different countries. It's been studied by us and others in original investigations and described in articles and textbooks. And the framework is now included in deprescribing protocols that are really used around the world to help providers identify medications that can actually be stopped and should be stopped, especially for older people. And right now, we're working with investigators from 6 different countries. And this idea that we started talking about a long time ago has evolved, and we have now identified more than 100 prescribing cascades. And we are now creating a prioritized list of these cascades that clinicians can use to really help them more quickly identify prescribing cascades. And we're exploring how these prescribing cascades may in fact impact women and men in different ways. Now, this information that we're working on now will inform deprescribing protocols that will really be tailored to older women and men, with, of course, the aim being to reduce medication harm. So, as a geriatrician and a scientist, my research combines women's health and healthy aging and really focuses on what I think is the often overlooked intersection to study women and aging. Older women face a series of important challenges that I'll discuss next. But these challenges are related to issues around congregate care, optimizing medications, loneliness, and issues around the need to address gendered ageism. Now, the vast majority of older women live in their homes in the community, and I think it's fair to say that most older women want to stay there in their homes. It's also important to know that women make up the majority of nursing home residents. This may be in part because women tend to be caregivers. They're the one that's providing the care, and when they need care, there may not be someone to provide it for them. About 70% of residents in nursing homes or long-term care are women. 80% of them are 75 years of age or older, and they have multiple chronic conditions, including things like dementia. So we need to find ways to support older women so that they can get the care they need when they are in a nursing home type settings, and when appropriate, get the care they need to stay in their own homes. Another important challenge for women relates to medications. I think it's important to note that medications are very important for all people, and they're very important for women. But 2 out of 3 older people are taking 5 or more medications. 1 in 4 are taking 10 or more medications. And while these medications are important, there are some concerning pieces. One is to note that potentially inappropriate medication use is highest in older women. Those are women over the age of 85. And this is important because these older women are more likely to develop drug-related events, adverse events that can lead to harm that could potentially be prevented. So we need to find ways to tailor drug therapies to the specific needs of older women in order to reduce medication harm. Loneliness impacts everyone, and it's a particular issue for older women. I think it's an experience that maybe many of us have gone through during COVID, and so something that we can probably relate to. Among older adults, 1 in 4 live alone, and women are twice as likely as men to live alone. And it's important to know that 40% of the women who are living alone feel lonely. Now, this is important because loneliness impacts health. Important to note that the former US Surgeon General says that the health impact of loneliness is like smoking 15 cigarettes a day. So clearly we need to find ways to reduce loneliness to improve health. Now, women also face discrimination, based on both their age and based on their sex. And this is something that we call gendered ageism. And it's something that often, I think, goes unrecognized. But if you think about it, gendered ageism is a bit of a thread that contributes to why perhaps there are more women in congregate care, why women are more at risk for medication harm, and why women are perhaps more likely to be lonely. Gendered ageism is reflected in so many of the things that we do on a regular basis. One is it relates to pensions. So as an example, relative to men, women are less likely to enter the paid workforce. And when they do, they spend fewer years in the paid workforce. They tend to earn less than their male colleagues, and they tend to take more time away for caregiving. And as a result of that, the OECD has reported that pension payments are on average more than a quarter less for women than for men. So we need to address this gendered ageism. So to improve health and well-being of older women, we're soon to be launching the Women's Age Lab. This is a way to use science to address these unique health and well-being needs of older women. Now, to our knowledge, this will be the first and only center of its kind, and we will improve the lives of older women by really building on evidence-based medicine. Now, I think it's hard to imagine that despite older women, representing more than half of the older population, we're really unaware of another sort of center of this kind that focuses specifically on older women. So we will focus on priority areas to improve the lives of older women. We'll look at addressing gendered ageism, as this is an important theme. We'll reimagine opportunities to age in place, and we'll explore how congregate care can be redesigned. We'll look at this issue of medications and find ways to optimize these medication therapies so that they're really tailored to the needs of older women in order to reduce this medication harm. And we'll also be promoting social connectedness as a way to reduce loneliness. And through this process, we aim to change the way that we think, feel, and act toward older women. And a tool that we will use, a cross-cutting tool, is to promote the reporting of sex and age disaggregated data in all fields as a starting point to really learn about older women and men across diverse areas. So in terms of strategic objectives, we'll use science to create the knowledge. We will test practical and scalable solutions to improve the lives of older women. And we'll disseminate this information using stories and other strategies with the goal being really to increase the public awareness and to really drive policy change. And through this, we aim to lead to better health and social care for older women. In order for science to have an impact, I really believe that we need to go beyond some of the traditional ways that we've made science available. So we need to work to make the science accessible to the public and make it accessible to decision makers. We need to actually translate research into practice so that it can be used. And we need to advance intergenerational solidarity. I think this is an interesting idea to think about. It's about really breaking down the silos between, for example, research on younger women and research on older women. And it's about mentoring the next generation of researchers and bringing younger people together with older people to find ways to address this important challenge. And improving health and well-being for older women needs to be done by including older women in all steps of the process. And of course, we're working to advance gender equity in healthy aging. So my career as a geriatrician and as a researcher, I think really does illustrate, the life course approach. So my son, who came with me as a baby to present my very first research paper that I did at Harvard, is now growing up, and here he is in the middle with my two other children. And my research on equity issues for older women, which really started at Harvard, and now this interest is being crystallized with the creation of Women's Age Lab, focusing specifically on older women. And I think it's fair to say that the mentorship that I received at Harvard and the collaborators that I first met there have really been invaluable. And these collaborations continue to this day. Now, as we think about this focus on older women, the true value of this research center is inspiring others to get involved, because I think the challenge of improving the lives of older women, it is bigger than any one of us. So your collaboration is certainly welcome. And this focus on women and aging is, I think, an important reminder of the life course. We are all aging. And ultimately, I think it's important to remember that research about aging and women impacts all of us. So thank you.
That was great. We are all aging, and I love the pictures, right? 102 to baby. Couple of questions. Am I hearing you say we need more geriatricians?
That's an interesting issue. Yes, I think we do need more geriatricians, but at the same time, I really don't think that is the answer. When I think about our own context, here, we have something like maybe 304 geriatricians for our entire population. So this means about one for every, something like 20,000 older adults. So clearly, not enough to provide care. And even if we increase this number, you can imagine it would be quite a slow process to be able to have the number of geriatricians we would need to have to really make an impact. So I think we need to pivot. So instead of thinking about necessarily having more geriatricians, I think it's more about how geriatricians in the future maybe need to think about using their skill. So maybe what they need to be doing more, or what geriatricians need to be doing more, is thinking about how they can apply their skills and how they can teach others about the principles of geriatric care so that they can apply that to their patients. So I think it's the idea of building capacity more broadly. And that would start with, working, for example, with primary care physicians and their teams that are really seeing the bulk of these patients, and starting with all of the healthcare providers, starting with, for example, the receptionists who are greeting the older individuals as they arrive, or talking with them on the phone, or who may have important things to contribute to the conversations and notice important changes that we need to think about, and getting the nurses and the pharmacists and everyone on the team very aware of what you need to think about when you're caring for older people. So I think this is where we need to start, and then to step back a little bit further to some of the things that we're talking about here. I think it's really important to also focus on getting the research base in place so that we really have the information that we need that can then be used to inform care and make sure we're providing the best care to older women and men. So So I guess the long and the short, yes, we could use more geriatricians, but I think the challenge is much bigger than that, and we need to think in a much different way about how geriatricians are able to have the greatest impact in improving the care for older people.
Yeah, so infusing sort of a sensitivity to elder care from start to finish for the patient experience and in research, right? That's what I think I'm hearing you say.
Very much so.
My second question is, could you talk a little bit about how COVID has affected this population?
Well, I think COVID has really magnified the importance of just about everything that I talked about here today. You know, when we think about the issues, you know, the areas that I discussed that I said, you know, were particular challenges and things faced by older women, I think the importance of each of these has been magnified. So, for example, we talked about congregate care, and we talked about that as an important place where, you know, we need to think about how we can improve that setting. Well, congregate care was the setting where, you know, many of the deaths occurred during COVID-19, certainly in our country and in many others. And this is really important because, you know, these nursing homes are home to mostly women. So it does, you know, make it even more and more important to focus on how do we improve care and congregate care settings so that, you know, things like COVID are not a problem for this group in the future, and just to improve quality of life for people living in those sorts of settings. And it's also, I think, elevated the importance of how do we find ways to, where, when it's possible, support people to stay in their homes, because that's often what people want. And I think we need to think creatively about ways to do that when it's appropriate. You know, another issue we talked about is loneliness. And I think I mentioned that during COVID, I think we all started to get a taste of what that is like. And I think the isolation that was experienced before COVID was really magnified for older people, and especially women. I mean, you know, if you can imagine when it wasn't possible for family and friends to visit or to be involved in your usual activities, you know, this takes, you know, quite a toll, you know, not only on mental health, but also on physical function. You know, people were not able to get out and walk and do things that they may normally have done. And, you know, that also, you know, has a negative impact on health. So again, reinforcing that loneliness is something that we need to be thinking about and finding ways to prevent and reduce. The issue about medications, you know, I said that the use of potentially inappropriate medications is highest among older women. And I think there was concern during COVID that perhaps medications were being used when maybe in usual times, instead there could have been more support from family or caregivers that would have made these medications not necessarily needed. So I believe there probably was an increase in potentially inappropriate medications, and that of course can lead to harm. So it circles back to the need to thinking about medications and how best to use them in this population. And then the issues around gendered ageism, I think, probably also became greater during COVID. And I think the gaps in the care that are available for older people, you know, became more obvious. And so this is something that we certainly need to address. So yes, I think COVID has just magnified the importance of all of these issues and has really, you know, called to us and brought to our attention the need to be very focused on finding ways to address these issues to improve health and well-being for older adults and women in the years to come.
Thank you so much, Paula. This has been fabulous, and I hope it's raised awareness in a way that I think perhaps we didn't know about before. I appreciate it. Thank you, everybody, for joining us today, and keep keep checking in for the next talks for this week in the reunion. Take care.